Okay. Still waiting. We are live. Hello, everyone. Welcome to another neurology webinar. This week is going to be on Vertigo. We're delighted to be joined again by Dr. Jamie Talbot, a neurology registrar at Exeter in the southwest of England, and he's going to talk us through Vertigo. As always, all our content is accessible if you look through the previous webinars on the Medal website. You'll be able to see recordings of it as well as on YouTube, and then keep an eye out because we've got sort of 3 or 4 more sessions coming up. We've got one on Monday on acute stroke, and then the week after we've got one on traumatic brain injury, and we'll finish on Friday the 20th of May with neurological infection, and then we're going to take a little break while we try and work out what other sort of neurology webinars we want to do. As always, you can get feedback. If you fill out feedback, you can get a certificate for your portfolio, and everything's available on Catch Up as well, as I've said. So Jamie, over to you.
Brilliant, thank you very much. I'll just boot up my presentation. Perfect. So hopefully everyone can see that okay?
Yeah, that's available.
Wonderful. So so the topic of my talk is vertigo, a systematic approach. And there will be some multiple choice questions and voting later on, so I'll just stick the session number up on the screen now. If people want to log in, I'll keep that up for about 30 seconds or so. I'll talk about the talk in the meantime. I'm James Talbot, one of the neurology registrars in Exeter, and we see quite a lot of patients presenting with vertigo. Although I guess ENT specialists are probably a bit more au fait with some of the diagnosis and management, so the talk will probably be a bit polarized towards how we see things as neurologists, and how we kind of make clinical decisions, and diagnostic clues, and what's important to us. But hopefully it'll be useful to all you as well. So vertigo, or dizziness. I think the first thing when it comes to people describing their symptoms as feeling dizzy is that there are a lot of different connotations and a lot of different words that people use to describe completely different symptoms. And these are probably the most common of those descriptions, even though there's many more. Dizzy and giddy in particular are the 2 terms which cause all kinds of confusion and have all kinds of different meanings. So as a case in point, I'll start with a case study. An 80-year-old woman presented to the emergency department after a fall at home. She reported a 4-week history of feeling giddy when walking in between rooms in her house, culminating in a fall and an ambulance being called. Her medications included benflumethiazide, bisoprolol, ramipril, and simvastatin. On examination, she had a couple of beats of gaze-evoked nystagmus on testing eye movements and was slightly unsteady and cautious on her feet. Her blood pressure was 105/70 with a heart rate of 70 beats per minute. She was quite pale and had a loud ejection systolic murmur. Her bloods revealed a sodium of 124 and anemia of 90. So I think that is just a example of the many different reasons that someone can complain of feeling giddy or dizzy. Low sodiums, anemia, low blood pressures. So I think it's very easy to kind of slip into the problems of what people actually mean. So when we talk about vertigo specifically, we mean a sense of movement, either internal or external movement. And the common descriptions people give are spinning, like they've just come off a roundabout, although also any kind of movement, swaying, tilting, veering, being pulled to one side, being on a ship. Those are the common descriptions of movement, although in themselves they're very different entities. So a good question that you can ask is, do you mean that everything was moving around you, or that you felt you might pass out? Because those are probably the 2, that's the a good distinguisher if people are actually experiencing vertigo, or whether they're experiencing lightheadedness or pre-syncope. So I've this is a systematic approach to dizziness rather than vertigo, but I think the first point is to know your enemy and to know what people are talking about when they describe dizziness or giddiness. And a lot of people advocate these 4 general symptom descriptions to describe how people are feeling. So vertigo, the world's moving, disequilibrium, which is more of a feeling of unsteadiness, lightheadedness, my head's swimming, and pre-syncope is I'm going to pass out. And even those descriptions aren't perfect and they kind of blur into each other, but they're good sort of groundings to think about. Traditionally, vertigo is caused by things affecting the vestibular system, or alternatively have central causes affecting the sort of cerebellum and brainstem. So things like vestibulitis and BPPV, Meniere's. Disequilibrium, again, it's more kind of general. All those things can also cause a kind of general feeling of unsteadiness rather than frank vertigo. But again, you're sort of getting into the territory of other causes of things like peripheral neuropathy, where people feel unsteady on their feet, and ataxia, balance problems. And then there's this entity PPPD, which is basically a or 3PD. It's basically kind of this perception of dizziness, and a lot of people lose their confidence because of these feelings, and that just kind of makes them feel unsteady in its own right. Lightheadedness is often drugs and low salt and hypoglycemia, stuff like that, and sometimes there can be anxiety component in the mix. And pre-syncope can generally be thought of as things where there's an interruption of the blood supply, so if I usually cardiac, vasovagal, or orthostatic mechanisms there. So getting on to vertigo, I think the second question to ask is it episodic or is it continuous? And if it's short-lived with clear provoking factors, especially head movements, it's probably BPPV. BPPV is the most common cause of vertigo, and typically causes a short-lived vertigo with precipitating movements. So if it's triggered by sort of things like sitting up, turning in bed, and then it sort of lasts about 30 seconds and goes away, it's probably BPPV, and you don't have to think too much more. So the third question in the systematic approach, and this is probably the most difficult one, and it's this is a question for vertigo which is kind of persisting, that's kind of come on and it's ongoing, is it central or is it peripheral? Central means that there's a problem within the substance of the brain or the brainstem, and peripheral means that it's something within the vestibular system, so within the labyrinth and the semicircular canals or the nerve. In terms of questions that you might ask to kind of narrow down whether something's central or peripheral, peripheral vertigo, they often say, is more severe. Again, all these factors and questions are not perfect, but it's a kind of a general rule of thumb which is often disproved. Are they old or young? Obviously, if they're very old, you're going to have a much lower threshold to think about stroke. However, if they're sort of in their 30s, stroke is suddenly very low. Any associated cranial nerve symptoms, things like gaze paresis, facial weakness, bulbar symptoms, things that would point to a central cause. In the history, do they have a history of recurrent vertigo? And that's quite important. Again, thinking about things like vestibular migraine, if there's a kind of repeating pattern of these attacks, because obviously something like stroke is usually a one-off, but vestibular migraine can be a sort of repeating entity. And then thinking more broadly, was there a trigger to the acute vertigo episode? So often there isn't a trigger, but some things can precipitate vestibular problems, and the culprit, gentamicin, is a culprit for causing these sort of problems. So if there's any recent antibiotic courses for gentamicin. Again, think about the ears, any hearing loss, any tinnitus. I guess you'd be thinking along the lines of Meniere's, labyrinthitis, acoustic neuroma, vertigo is usually quite a rare symptom of acoustic neuroma. In almost 9% of cases, the key symptom of acoustic neuroma is slow hearing loss. So so it's not a common cause for vertigo. Do they have a history of migraine, or especially migraine with aura, to suggest that these could be migrainous? Any neck pain or injury to suggest, again, vertebral dissection or stroke. And again, any recent head injury. Head injuries are very common causes of vertigo, which usually kind of clears up over a period of months afterwards. Head injuries, they dislodge a lot of stones, otoliths, and they can cause BPPV. And sometimes you can actually have dehiscence of, the bone can kind of separate and cause a kind of vertigo due to superior canal dehiscence. So those are some useful questions to kind of come up with in the history to kind of refine the diagnosis a bit. And then the clinical examination is very helpful, with the caveat that all the clinical signs are not perfect, and they often, when differentiating peripheral and central causes, you might see the same things in either, but there are some general principles which can help pin it down. In terms of the clinical examination, nystagmus is important, looking at the nystagmus. Again, doing a full cranial nerve exam to check if there's any obvious brainstem or cerebellar signs, a kind of Danish symptom load. And then the hints exam, of which nystagmus is a component, but I'll talk about that in a bit. So I've got a lot of videos coming up, which I've basically commandeered from the internet. With I've tried to credit the sources, but I think it's useful to see some of the clinical signs so that you know what you're dealing with. So I'll show you this video. I'll let you have a look at it, and then I'll have a talk about it. Okay, so I'll play that video again and just talk at the same time. So nystagmus can be described in different ways. Obviously, usually when we're talking about nystagmus, we're talking about a sort of jerk nystagmus, where we have a slow phase and a fast phase. The slow phase is kind of drift across to one side, and that's due to the disruption of the whatever circuits. And you see the fast phase, the corrective saccades, where the eye comes back across, and that's the fast phase is basically the what we refer to as the direction of the nystagmus. And the direction of nystagmus can be horizontal, or it can be torsional, as in this video. So if you look carefully at the video, you can see the eyes are basically kind of rotating rather than sort of necessarily sort of flicking in one particular direction or horizontally. There's this rotation to them. So this is described as a sort of torsional component of the nystagmus. You can see it more clearly in the right clip there. The eye is just kind of rotating slightly anti-clockwise, and it can be quite difficult to appreciate sometimes. But if you see torsional nystagmus, that's usually a good indicator that the nystagmus is peripheral. However, that's usually peripheral nystagmus it's a kind of mixture of some torsional nystagmus mixed in with a horizontal nystagmus. I think this video is really kind of just rotational, but I thought it was a good video for just kind of showing you what you mean when you say torsional or rotational nystagmus, the way it kind of rotates around. So this is horizontal nystagmus, and seeing the phase, the direction of the nystagmus is very important, and you can it gives you a bit of a clue as to whether the problem is central or peripheral. So the chap in this video has unidirectional nystagmus, so it's only beating in one direction, which is to the left. So you can see there's nystagmus in the primary position there. The eyes are kind of beating to the left. You see the fast phase to the left. He looks to the left, and the nystagmus accentuates, and it's still beating to the left. And he looks to the right, and even there you can see the fast phase is moving to the left-hand side. So it's only really going in one direction. And unidirectional nystagmus is, again, hints a bit more towards it being a peripheral problem rather than a central problem. This, on the other hand, is bidirectional nystagmus. So looking to the right, you can see the fast phase of nystagmus beating to the right, and she looks over to the left-hand side, and you can see that the the eyes are beating to the left. So I'll show that again. Looking to the right, eyes are beating to the right, and then looks over to the left, and then nystagmus going to the left-hand side. So it changes direction, and that would be more indicative of a central cause. Look, this one's a bit subtle, but this shows downbeat nystagmus. So again, this patient's eyes, there's no horizontal component. The eyes are just kind of beating downwards. And if you see horizontal nystagmus, vertical nystagmus, and particularly downbeat nystagmus, that is much more suggestive of a central cause. Certainly, if you saw this patient, you saw the nystagmus beating downwards, you would be much more concerned about something like multiple sclerosis or some sort of centrally mediated nystagmus. So I mentioned the HINTS exam earlier on, and this is kind of an add-on to the normal clinical examination. HINTS basically stands for head impulse test, nystagmus, and test of skew, and they're kind of the three different things that can give you some idea about whether a problem is peripheral or whether it's central. And I'll show you some videos of that. The most useful of those tests is probably the head impulse test. But I'll go into detail now. So this is we'll start with a test of skew. So this is how you test for it. Basically, you've got someone to fixate, and then you're just moving the hand, covering each eye in turn, and then switching it across. So that's, I think it looks like that's a normal test as far as I can see, but you know, she's a bit far away. So that's how you test it. And this is an example of a positive test. So you cover the left eye, and then you can see that there's a corrective saccades of the right eye. I'll play that again. So the right eye, no real change there. The left eye, and you can see the eye recorrect the alignment of the eye. So that is, if you see that with someone with an acute vertigo symptom, that would be more suggestive of a central problem. So sort of stroke or MS or something like that. However, as a test, it's not perfect, and a lot of people have you know, just squints and latent strabismus, and which this test can pick up as well. So again, it helps. It can kind of help in the clinical thinking, but it's as a test, it's far from perfect. This is an example of the head impulse test. This is probably more useful. So this is how it's performed. You ask the patient to keep their neck nice and lax, to keep their eyes on your eyes, and then you're quickly moving the head back one way or the other. So if you see this, its head's moving quickly to the right, and there's another way it gets moved quickly to the left, and then I think it does another movement, and there you go, movement to the right. And this is a positive test here. I'll play it again. So you can see when he moves it to the left, he moves the head to the right, there's a corrective saccade, so you can see the eyes kind of catch up there. Not so much movement when he does it to the other side. And if you watch again, moves it quickly to the right, and the eyes just catch up. That's a positive test, and indicates it implicates because the eyes are catching up when he rapidly moves the head to the right, it's implicating the vestibular apparatus on the right side. So it's kind of a suggestion of a peripheral vestibular problem, and it implicates kind of the right vestibular apparatus. This is an example just of the head impulse test where it seems to be normal. It's a bit more difficult to see this one, I think, but if you keep an eye on the eyes, there isn't really a corrective saccade. So the eyes basically remain fixated on the target, and there's no sort of correction there. So that's a normal test. That's what you'd probably see in URI. I do think that as people get older, people can develop a bit of vestibular disturbance, so sometimes you do see the positive test. So again, as a test, it can't be fully relied on for, but again, it's another bit of useful information that can help hone in on the problem. All right, so I will proceed by a few of these voting rounds. Basically, hopefully you've got the app up, but we'll bring up the voting in a sec. So this is the first case. A 37-year-old athlete acutely developed symptoms of rotational vertigo on getting up one morning, lasting a matter of minutes before fully resolving. However, he suffered further attacks, particularly on looking up quickly, bending down or turning in bed, with significant nausea. He had a history of migraines, but was otherwise fit and well. Basic neurological and physical examination did not reveal any abnormalities. So, let's just close that. Oh, that was quick. So I'll give people a bit of time just to vote on this one. Just to hide the polls, so I don't want to bias anyone's opinion. Okay. So we'll have a look. So the majority of you chose BPPV, and that is the correct answer. Oops. Yep. So benign paroxysmal positional vertigo. So this is a peripheral problem. This is characterized the symptoms by short-lived attacks of vertigo, and often with provoking movements. And it relates to you've got within the vestibule, the utricle and saccule, you've got basically little crystals, little stones, which are embedded in a kind of matrix, a kind of gooey matrix, basically, and they can dislodge, and they can end up in these canals. You've got three canals. You've got the posterior canal, which kind of juts off at a bit of an angle, the horizontal canal, which is kind of in plane with the horizontal plane, and the superior canal. The crystals can get dislodged into one of these canals, usually the posterior canal, and they basically disrupt they stimulate the hair cells, which are kind of sensing the movement of the fluid in there, and they activate, and the result is a feeling of vertigo and nystagmus that you can observe. As I said, the majority relate from stones in the posterior canal, and then the horizontal canal counts for the majority of the others, so about 5 to 30%, and the superior canal is a really very rare cause of BPPV. That's a picture of just what it looks like with the stones. There is something called cupulolithiasis, where you can get these the debris can kind of stick to the cupula. That's basically this protuberance at the ampulla, which basically stops stones coming out. It's kind of blocking the path of it, so they can stick to that, and they can be a bit more difficult to treat. Or then there can be that's cupulolithiasis, or you can have the canalolithiasis, where they actually end up within the semicircle canal and cause problems there. So the diagnostic test, which everyone usually knows about to test for BPPV, is the Dix-Hallpike test, and this is a test of the posterior canal. So sit the patient up on the bed, turn the head 45 degrees towards the ear being tested, and then you sort of bring the head down quickly so that the head's just overlying the couch, and then you sit and observe, ask the patient to keep their eyes open and observe for any nystagmus. And you get a positive test if it not just provokes symptoms and nystagmus, but provokes the appropriate nystagmus. You tend to have these four things which you should see in this when doing this maneuver. So latency, there's a kind of period, it's usually a second or two before the development of symptoms. Torsional and upbeat directionality. You remember I told you before that the upbeat nystagmus is usually an indicator of a central problem, but obviously the head is at a different angle here. So and the nystagmus that you tend to see relating to these canals is usually it's in the plane of the canal. So it's and that's essentially why you have to rotate the head 45 degrees in this test, because you're kind of pointing the head towards, to be in line with the canal to provoke the most symptoms. So you see this kind of torsional nystagmus, which is beating upwards, and then the nystagmus, I think, reverses if you come up, and also you see this fatigability. So if you repeat the test several times, you'll see the effect diminish with each subsequent test. So this is a video of a positive Dix-Hallpike test. So you see there's a bit of latency, the eyes move, and again you can see there's that sort of torsionality to it. You can see that rotation, but there's also this kind of jerk nystagmus beating upwards. That's it, and then it kind of all settles down after that. Bring it back to things. So it comes down to the left. This is testing the left canal. Bit of latency, then the nystagmus builds up. She gets symptoms, and then you can see that the eyes have this upbeat nystagmus with this rotational component to it, and then it kind of simmers down. So that is a positive test and indicative of left posterior canal BPPV. If you do diagnose posterior canal BPPV, there are manoeuvres which can be curative, and the well-known one is the Epley manoeuvre. And I'll just play the video to see what this is like. So you turn the head to the symptomatic side. So if it's left canal, you turn the head to the left, bring the head down, keep it, there's about half a minute between these steps, turn the head to the right, and then the body turns onto the right hand side, again another 30 seconds to a minute or so, and then come up like that. I'll play that one more time just so you can see. So the head comes to the left canal, comes down quickly. So that's basically the same as a Dix-Hallpike, but then the head comes across to the right hand side, and then again this is just repositioning the canal to try and get the debris to move back into the balance organ on the right side, and then the head comes up, and that usually has quite a good success rate. I think in the region of about 80% or so. There are other options. So this is called the Simon manoeuvre. I think that's how you say it. Again, this is also treating right PPV. So again, this manoeuvre is sometimes done if the evidence isn't successful, and it can so head goes to the other side, to the balance problem, and come quickly down to the side that's the problem, to the right side in right canal BPPV, on the side for about a minute, and then you just change sides to the other. Sometimes you see quite aggressive Simon manoeuvres being done. You really see people kind of throwing down on one side and around to the other side. I'm not sure if that has more advantage to the other one. I guess you're creating more force, so so there's more chance of kind of getting those crystals back into where they should be. But and then so that's talking about posterior canal BPPV, which, as I said, is by far the majority of cases, probably between 60 and 80% of them of BPPV. But as I said before, if the Dix-Hallpike test doesn't provoke nystagmus or creates the wrong type of nystagmus, you should consider the horizontal canal BPPV with a typical history. Whilst posterior canal BPPV often provokes symptoms when people are lying down, so patients often report symptoms when they're turning in bed, or when they're kind of extending their neck up or bending down. With horizontal canal BPPV, the vertigo, which is usually very severe, is usually whilst upright and after turning the head. And there's a diagnostic test which I'll show you in a sec called the supine roll test. that test basically tests both the horizontal canal, so it's a bit of a difficult test to interpret, which I must admit I would not myself feel confident about. I've put a table down there which just shows how you would interpret the test. It's usually based on how intense the nystagmus is and kind of whether it beats towards the ground, whether it's geotrophic or in the opposite direction. So and it gives you an idea of whether it's actually in the canal or whether it's adherent to the cupula in that horizontal canal. This is the supine roll test of the patient. It's lying down, turn the head to one side, and you just observe for any nystagmus, and then comes to the right hand side, and then you just look for nystagmus. So it's quite a simple test. It's more simple than the Epley manoeuvre. Okay. Right. So if we go to voting round 2, an 80-year-old woman attended her GP due to recurrent attacks of vertigo. She often experienced a feeling of fullness in her right ear and fluctuating tinnitus, sometimes preceding the vertigo attacks. During bouts of vertigo, which were severe and lasted a number of hours, her hearing was impaired in the right ear. After attacks, she felt very tired and slept for many hours. Over the years, the hearing in her right eye had gradually been declining. So that's the case history. So if we open the poll, so I think I can present full screen here. Let's have a look. All right. Meniere's disease, which is the correct answer. So so most of you got it. Well done. Oh yeah, sorry. I put an MRI in there just to kind of try and confuse you. I forgot I put that in there. That's a normal looking MRI. There's no evidence of any acoustic neuroma in there. So Meniere's disease. There's still some confusion as to what does cause it. Traditionally, it's thought of being a fluctuation in the endolymph pressures within the labyrinth, but there's some question of whether it's an epiphenomenon. I won't get into all that. So usually patients present between the age of 30 and later on, but it's usually around the 6th decade. So it's usually older patients. And there's 4 classic symptoms: is fluctuating tinnitus, fluctuating vertigo, fluctuating hearing loss, and fluctuating oral fullness. The average attack lasts 2 to 4 hours, although there's a lot of variation, and they're often much shorter than that, or even much longer. And following a severe attack, most patients are exhausted and need to sleep for several hours. But I'm not sure how surprising that is, because probably would take it out of you. And then between the acute attacks, most people are free of symptoms or note mild imbalance and tinnitus. And there can be, it's very variable. You can have months, you can have years between attacks. And in most cases, especially as time goes on, patients tend to get progressive hearing loss in the affected ear. And a lot of patients get symptoms affecting the opposite ear as well. And the pattern of hearing loss is usually a kind of low frequency hearing loss. So the lower frequencies tend to be worse affected. And this is quite an interesting video. So the invisible hand. So this is a CCTV footage of a drop attack, I guess he said, which is a patient with Meniere's disease. So I'll play that again. So this is a reason why many patients with Meniere's get very anxious and suffer a lot of depression and things like that, because there's thought to be a very sudden change in pressure, and can cause people to really topple over and have this violent falling over, a kind of drop attack. Drop attacks in their own right are their only kind of descriptions. There's lots of different causes. They're usually they're often associated with epilepsy, the kind of atonic epilepsy and things like that. But Meniere's disease is a known cause of drop attacks as well. In terms of treatment for Meniere's, again, this is kind of certainly exiting my area of expertise, but you can give these kind of vestibular sedatives, things like prochlorperazine, betahistine, which again is an antihistamine. I think some patients, especially who suffer drop attacks, they can use gentamicin to literally kind of destroy the vestibular system to kind of prevent horrible, unpleasant symptoms like that. There's something called vestibular rehabilitation, which can be very useful for patients with vestibular problems in general, and there's also things like balance physiotherapy. So the vestibular system has a good it does kind of recover well, and people adapt to problems quite well, and so having that specialist support to help is very useful for patients. And obviously audiology and things like that if there's hearing aids and things. I say a lot of patients have anxiety and things, so CBT and relaxation therapies can be useful. Apparently there's some I wouldn't say evidence, but some people advocate a low salt diet and avoiding things like alcohol and caffeine, stopping smoking, so and that's kind of recommended on the NHS website. But as I said, my knowledge of Meniere's is quite limited, and it tends to be ENT GPs who deal with it. So, voting round 3. A 47-year-old patient was admitted to the stroke ward with an attack of vertigo lasting around 24 hours. The neurological examination was normal except for a few beats of left beating nystagmus. Examination was limited by eye closure and severe nausea. There was no associated headache. Her MRI with diffusion-weighted imaging performed the next day did not show any evidence of acute stroke. She gave a prior history of at least 5 identical attacks and mentioned a long-standing history of migraine with aura. She often experienced a sense of spinning on turning her head too quickly. Dix-Hallpike and supine roll tests were negative. That is the third case. So I open that and then present in full screen. So if everyone gets voting on this one. Give you 5 seconds. Okay. Vestibular migraine is the correct answer. BPPV. I'm surprised no one chose BPPV because there was I said about the slightly short-lived attacks as well. But then again, a lot of patients with migraine, a higher proportion of patients with migraine suffer with BPPV than the sort of aged-matched, other population. Mollaret's vestibulitis. I'm glad no one chose that one because there's no such thing. And PPPD. Yeah, that's not a bad shout, is it? Okay. So the answer is indeed vestibular migraine. And vestibular migraine is basically it's a difficult one. It's a difficult diagnosis, and I always feel that whenever you make it, you're never entirely sure. And it's this association of vestibular symptoms and migraine symptoms, and the presence or history of migraine is essential for a diagnosis, but the headache and vestibular symptoms do not need to temporarily coincide, and that's something which is I don't think I really realised for a long time. I always kind of assumed that a vestibular migraine was basically a migraine aura causing some vestibular symptoms, after which universally a headache would follow, but that's really not the case. And I'll show you the sort of diagnostic criteria for vestibular migraine in a second. As I said, BPPV is also commoner in patients with migraine, which makes things even harder, as is things like PPPD. So it can be very difficult pinning down the problem and really being confident. In terms of if you want to treat vestibular migraine, the general treatment is exactly the same as any sort of migraine. There's no particular preventive drug which seems to be better for vestibular migraine than any other. They're all as good as each other from the evidence that we have, although with the caveat of the being limited by the availability of that evidence. This is the IC, the International Classification of Headache Disorders criteria for vestibular migraine, and it's a bit difficult to work out. But essentially, to have a confirmed vestibular migraine, you need to have basically migraine symptoms associated with, so sort of headache and photophobia and stuff like that, associated with vestibular symptoms at least half the time. So that's a kind of vestibular migraine. However, if you look at the bottom, you can see probable vestibular migraine, which basically says that you need a diagnosis of migraine in the background, and you need to have had kind of 5 similar episodes, but you don't necessarily need there to be that 50% rule, and the symptoms aren't better accounted for by another vestibular problem. So it's basically saying you've got migraine and you have these kind of attacks of vertigo, which you can't find an obvious cause for. So it's quite generic. Okay, so this is the last voting round. A 25-year-old woman presents to the emergency department with a sensation of spinning and nausea with unsteadiness on walking. She was otherwise well with no relevant past medical history. On examination, her speech sounded a little slurred, and she had a coarse postural tremor of the right arm. Okay. Right. So I'll give you a bit of time just to vote for that one. Okay, 5, 4, 3, 2, 1. Stroke, migraine. It's quite interesting, isn't it? A mix. So stroke was the most common one here, and it's kind of somewhat of an even split between the others, with multiple sclerosis getting a quarter of the vote. There was a video with this actually, which I should have showed you as well. But this is the video. Sorry if that would have changed everything for someone, but that's the pattern of nystagmus that she had. So the answer in this case is multiple sclerosis. I'm interested that stroke was the most popular choice there, because being a young woman, the multiple sclerosis would probably be a more likely a kind of cause of symptoms. I don't think, did I say, I didn't really say how quickly the vertigo came on, because that would obviously be a very important piece of information, because obviously if it did come on instantaneously, then you might more strongly suspect a kind of stroke or something like that. So this nystagmus here, show it again, called pendular nystagmus, which is most pathological, or at least either congenital or pathological. What you're seeing here, so there's no sort of fast or slow phase. The nystagmus pattern has a kind of sinusoidal appearance. It's kind of it's like a sine wave. There's no, rather than being a kind of slow drift in one direction and then a fast phase back to the other, you're basically just seeing a kind of an equal left and right, which is quite even, a bit like a pendulum going back and forth, I guess. So and that is the most common acquired cause of that is multiple sclerosis, and the location of that lesion is usually the central tegmental tract, which I've helpfully put on one side. So you can see on that diagram that you've got the red nucleus in the midbrain. You've got the inferior olivary nucleus in the medulla, I think that's. So there, that's connected via the central tegmental tract, and then you've got another sort of connection going to the dentate nucleus, and that's called. There's a triangle called the Molleret's triangle, which is kind of a neuroanatomical thing. So the case, in her case, her postural tremor would have been a rubral tremor, a kind of severe sort of rubral tremor relating to a problem around the area of the red nucleus. And some patients with problems in this area get a funny symptom where they get palatal myoclonus as well. So you get these kind of funny, rhythmic kind of movements of the soft palate. Again, these things are rare to see, but again, just think about things on a neuroanatomical perspective. I guess the case in point with her is that there's she had during the examination she had neurological signs which were which you wouldn't necessarily which point to a central cause. She mentioned her speech is a bit slurred. She's got this tremor, ataxic, so she's so there seems to be a central problem going on, and in someone of her age, multiple sclerosis would be the most likely diagnosis. And with these pendular nystagmus, as I said, there can be other causes, and sometimes you see it in people who are born blind and in sort of congenital forms of nystagmus. Great. So that is the last case and the end of the presentation. My main messages is dizziness, and the term dizziness is extremely wide-ranging with a dizzying range of connotations. And the first step, I think, is just to define exactly what patients mean by dizziness. And even then, it can be a minefield. Even this week, I found myself going mad trying to understand what someone meant by their symptoms. Lanes of traffic kind of floating above her eyes and stuff. I still have no idea. So trying to understand what people mean. In terms of us neurologists, and also, but I think importantly, just in medicine, general acute medicine, the main question is, does the vertigo represent a peripheral or central vertigo? And there are some clinical clues. As I said, a good neurological examination, cranial nerve exam, is very useful. If you see anything abnormal on that, then you start to think about central causes more. And the HINTS exam can pin things down to some extent, especially the head impulse test. However, the tests are imperfect, and on so many occasions, I have seen patients who have had, they've had a positive head impulse test, or they've had a kind of mild vertigo, or and you're sure it's going to be one thing, and it turns out to be something else. If you're sure it's going to be a central cause, and it turns out being a peripheral cause, and vice versa. So, despite the whole presentation talking about how to differentiate things clinically, I think it's actually very difficult. And I would say that if you're in any doubt as to the symptoms, which you probably should be, I'd have a very low threshold for imaging. Strokes are extremely common, and if you miss a stroke, that can be very bad. So don't, I wouldn't worry about kind of saving money. I'd just, if there's any doubt, get an MRI scan. Brilliant. So that is my presentation, my systematic approach to vertigo. I will go back to Alex and to you all just to see if there are any questions.
I think there was just one during the presentation, Jamie. Thanks so much for doing that. Okay. Do we know why people get tired with Meniere's disease?
To be honest, I have no idea. As I said, I'm hardly an expert in Meniere's disease. I will look it up. The thing is, I can imagine that just a terrible bout of vertigo would be pretty exhausting, and especially if it affects you in your 60s or 70s and stuff, it's you're probably more likely to get tired. But that's a very terrible answer. So I don't know. Sorry.
I think in terms of I think the only question I having seen someone with vertigo on the acute really recently is sort of, if they've had it for a few days, I guess it's sort of, you should be looking for an MRI, really, shouldn't you, if you're suspecting a central cause rather than a CT.
Absolutely. Yeah. Oh, yeah. I should have mentioned this actually. I meant to at some point. So, yes. So CTs are terrible for diagnosing posterior circulation strokes. MRI. So you just can't count on a CT to diagnose a posterior circulation stroke, and even MRIs are not infallible. So I think it's about 12% of scans are false negatives. So people have had strokes, but the scan doesn't show it. So that's 12% of patients. So even MRIs, the best we have, don't always pick up these strokes. So and certainly I've seen patients who've had a pure form of vertigo without any associated ataxia or clinical signs. And you do the scan, and sometimes there'll just be a tiny dot, some sort of tiny diffusion weighted change on the scan, indicative of a small stroke. So it's very, so these things happen, and strokes, as I said, they're very common, and they do slip through. And as I said, the clinical signs are misleading. It only in the last few weeks, I think, on our consultant ward round, the consultant did his head impulse test, and he was sure that someone was going to have a peripheral vertigo, and they ended up having a stroke. So so it happens to everyone.
I've got a couple more questions. What are the other differential diagnoses, which I'm sure is going to be a huge just for vertigo?
The other differential diagnoses, to be honest, for vertigo specifically, I mean it's mainly the ones I've mentioned already. As I said, acoustic neuromas and stuff, associated with vertigo, but actually it's quite rare. So vestibular neuritis is, which we haven't really talked about, I don't think it featured, is it's quite a common cause and causing a kind of acute vertigo symptom without necessarily any associated signs. They're really the main ones. It's one of those things where there isn't, while it can be quite difficult making the diagnosis, there's not a huge amount of things that can cause it. But again, there's a lot of things which can cause vestibular disease. So there's a lot of kind of triggers for it and things like that. There's infections, vestibulitis, things like that. There are drugs. But then if you look at causes, especially sort of bilateral vestibular dysfunction, if you look at these kind of pie charts of causes, a huge number of them are kind of idiopathic. There's a lot of the time a cause isn't necessarily found. Sorry, not a great answer either, is it?
How would a vestibular schwannoma present in regard to vertigo? Vestibular schwannoma being the specialist area of Plymouth's research expertise. So,
sorry, I missed it. Did you say that one more?
How would a vestibular schwannoma present in regards to vertigo?
Yeah, that's a very good. Yeah, it is a good question, and one that I was looking up. And the fact of the matter is, I don't think I've. I think it's meant to be paroxysmal vertigo, I think. But again, it's again, I can't think of a single vertigo case where they've ended up having a sort of vestibular schwannoma. As I said, they're usually hearing loss, and even because I read a thing recently which was kind of a specialist balance clinic telling about the number of patients with vertigo that had been diagnosed with acoustic neuroma, and even that was kind of a very small amount. It was kind of in the region of about sort of it's less than 1% or something like that. So it's a rare cause, but I think it's meant to be a kind of a paroxysmal vertigo, but I'm sure it could be a kind of more persistent thing, and probably a kind of general feeling of unsteadiness and balance, maybe not necessarily with frank vertigo. So maybe a kind of a sort of slowly progressive feeling of unsteadiness, maybe with some superimposed attacks of vertigo. That will probably be my what it sounds like from what I've read.
Okay, that is the only question we have. We'll give it another minute or so, and then we will head off, I think. Okay. So if anyone has any other questions. Okay. I will just continue. I will just continue promoting what's coming up then, while we just wait and see if there are any other questions. So yeah, thanks again for coming tonight, everyone. We have got our next session is on acute stroke, which hopefully will work time for anyone that was unfortunate to witness me furiously trying to get the technology to work the last time we tried it in March. That is on Monday at 8 p.m. So I hope to see you there. Like I say, everything is available online. I think a couple of people have asked questions. We generally try and upload the slide decks up on Medal within 1 to 2 weeks, and then there should be the full sort of video available to watch again, I think on here, but on Medal as well as on YouTube as well, if you want to look it up. And you can still get certificates and stuff. If you watch the video back on YouTube, there's still the option to fill out the feedback for your portfolio for any foundation doctors or anyone else coming up to ARCP. I know that sort of thing is incredibly important right now, for me as it is for everyone else. But yeah, there's no questions that have come through, so I think we'll say goodbye for now. Thanks again, Jamie, and
Thank you.